Good morning, Dr. PK. So I wanted to talk about two patients I saw recently, and both of them had something called pre-herpetic neuralgia. So both patients had this pain, shooting pain in part of their body, and they didn't know what was going on, and they went to urgent care. Both of them went to emergency room actually. The second one traveled from other country back to her home country, US, and she had pain in her left rib, severe degree, a burning kind, and getting worse with coughing. And she went to ER, all the labs, chest X were normal. ER doctor told him that she had this sprain in her ribs because of coughing. And she was given some pain medication, let go. 2 days later, she developed a rash in her anterior abdomen, left side, and in the ribs area, posteriorly and laterally on the left side as well. She was diagnosed with shingles. In fact, she did not even go to see anybody for a week until I saw that patient recently. And it was a late treatment for shingles, but I gave her treatment anyway. The treatment of shingles should be started within 48 hours. That's when it's effective. So I wanted to talk about pre-herpetic neuralgia and post-herpetic neuralgia. Why early recognition of shingles matters. As clinician, we often see patients with unexplained sharp, burning, one-sided pain, sometimes labeled as muscle sprain, rib sprain, dry pneumonia, pleurisy, or even cardiac causes, only for shingles rash to appear a few days later. This phase is called pre-herpetic neuralgia or prodromal neuralgia. Recognizing it early can significantly reduce complication, especially post-herpetic neuralgia, PHN, a chronic neuropathic pain syndrome. I'm going to break this down clearly. So shingles, is most of the people know by now in today's world that's a reactivation of Varicella-zoster virus, the same virus that causes chickenpox. After primary infection, the virus becomes latent in dorsal root ganglion, near your spine. Then it reactivates years later and travels along a sensory nerve, causing dermatomal pain and rash. Most commonly affected area is thoracic area, rib and abdominal region, thoracic dermatomes, T3 to T12, and it's usually unilateral. So what is pre-herpetic neuralgia? It's also called prodromal neuralgia. Neuropathic pain occurs before the rash appears. It's because of viral replication in the nerve. Inflammation develops in dorsal root ganglion. Nerve irritation occurs before skin involvement. Duration typically 1 to 5 days, but can last up to 2 weeks. How common? About 70 to 80% of shingle patients. Often misdiagnosed in early phase. Pain characteristic, sharp, burning, electric kind, deep rib and abdominal pain, allodynia, worse with touch or clothing. It may mimic costochondritis, gallbladder disease, kidney stone, pleurisy, cardiac pain. This explains cases like my patient. ER workup was normal, muscle strain was diagnosis, and rash appeared days later. What is post-herpetic neuralgia? PHN is defined as the pain persisting more than 90 days after the skin rash onset. It results from permanent damage to the nerve, central sensitization, and loss of inhibitory pathways. Now, how common is a post-herpetic neuralgia? The older you are, the more chance it is. So less than 50 years, there is a 5% chance. 50 to 59, 10% chance. 60 to 69, 15 to 20% of chance. More than 70 years of age, 20 to 30% of chance. But overall, 15 to 20% of shingle patients develop post-herpetic neuralgia. These factors: old age, severe acute pain, severe rash, and guess what? Delayed antiviral therapy, immunocompromised status. I told this patient of mine yesterday that there's a good chance she's going to have post-herpetic neuralgia because she did not seek the treatment for 7 days. Why early treatment matters? Viral replication peaks within 72 hours of rash onset. So early treatment reduces viral load, shortens rash duration, decreases acute pain, and lowers post-herpetic neuralgia risk. The window for maximum benefit within 72 hours of rash appearance. Or even earlier, if pre-herpetic neuralgia is strongly suspected, antiviral therapy, standard agents is cyclovir, valacyclovir, famiciclovir. They inhibit viral DNA replication by inhibiting polymerase enzyme. Clinical benefit is that there is shorter rash duration, faster lesion healing, reduced viral shedding, lower severity of acute pain, and modest reduction of PHN risk. Valacyclovir and famciclovir are preferred due to better bioavailability and less frequent dosing. What is the role of corticosteroid? A short course of steroid like a prednisone may help reduce acute inflammation, improve quality of life, and decrease acute neuritis. However, it does not clearly prevent post-herpetic neuralgia. It should always be used with antiviral therapy, and it should be avoided in uncontrolled diabetes or severe immunosuppression. Steroids are adjunctive. Acute shingles pain management, usually NSAIDs, Tylenol. Moderate to severe pain, we use gabapentin, pregabalin. Short-term opioids, lidocaine patches, capsaicin cream. And post-herpetic neuralgia, first line of treatment is gabapentin or pregabalin, maybe amitriptyline or topical patch of lidocaine or capsaicin, sometimes even duloxetine. Post-herpetic neuralgia can last for months, in rare cases for years. Prevent shingles by getting vaccine Shingrix for adults more than 50 years of age and immunocompromised adults more than 19. Efficacy is 90% prevention of shingles and 90% reduction in post-herpetic neuralgia. This is a major advancement in prevention. So if you see unilateral dermatomal burning pain, normal imaging, no cardiac abdominal causes, especially in patients more than 50, consider pre-herpetic neuralgia because early empirical antiviral therapy may be justified. So, thank you for watching.